Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 466 of our pharmacotherapy series, which majors in adult hematologic malignancies. The next case reads, GOR, a 66-year-old man, presents to his physician with a persistent semi-productive cough and increased fatigue. A routine CBC revealed a hemoglobin of 13 grams per deciliter, a WBC count of 34,000 cells per microliter, with 80% lymphocytes, and a platelet count of 175,000 cells per microliter. Blood pressure was 120 systolic, 70 diastolic, heart rate 64 beats per minute, and respiratory rate 23 breaths per minute. He was afebrile. Physical examination was unremarkable. He was prescribed azithromycin for possible community-acquired pneumonia and scheduled for a return visit in 3 weeks. At that time, his CBC results were hemoglobin 13.2 grams per deciliter, WBC count 32,000 cells per microliter, with 82% lymphocytes, and platelets 168,000 cells per microliter. Physical examination was unchanged. The chest radiograph was clear, and his cough had resolved. GOR was referred to a hematologist for evaluation of his persistent lymphocytosis. So my first question to you reads, what is the most likely cause of persistent lymphocytosis in GOR? Chronic lymphocytic leukemia is usually included in the differential diagnosis of any adult with persistent lymphocytosis, that is more than 5,000 lymphocytes per microliter in peripheral blood. Additional causes of lymphocytosis include transient reactions to acute infections such as influenza or mononucleosis, as well as other hematologic malignancies. To differentiate between benign and malignant lymphocytosis, examination of the peripheral blood or bone marrow morphology may be required. Patients with chronic lymphocytic leukemia commonly have lymphocytosis in both the peripheral blood and bone marrow, whereas patients with other disorders have a high percentage of atypical lymphocytes in the peripheral blood alone. The absence of fever or additional signs of infection without significant diagnostic or physical examination findings, together with the presence of mature peripheral blood lymphocytes, make chronic lymphocytic leukemia the most likely diagnosis for GOR. Immunophenotyping and cytogenetics of involved cells are required to establish the diagnosis, to provide prognostic information, and to determine therapy. Bone marrow biopsy with aspirate may be useful to determine the definitive diagnosis. GOR's bone marrow examination reveals normal cellularity with greater than 40% of nucleated cells lymphocytes. The immunophenotype indicates that peripheral blood lymphocytes are predominantly B cells and are positive for CD5, CD19, and CD20. A diagnosis of chronic lymphocytic leukemia is confirmed. Is GOR's presentation consistent with chronic lymphocytic leukemia? What is the prognosis for GOR's disease? What treatment is indicated at this time? GOR's cells were sent for routine cytogenetic analysis, which revealed a chromosome abnormality, deletion 11q. How does this affect his management? GOR has fatigue, infection, and lymphocytosis without lymphadenopathy, and these are consistent with low-risk chronic lymphocytic leukemia based on his modified Rye stage. Given his stage, GOR has an expected survival of at least 10 years. An accepted treatment modality for early-stage disease includes a conservative, watchful waiting approach. No clear advantage has been demonstrated in treating asymptomatic patients in early-stage disease with alkylator-based chemotherapy as compared with deferred treatment. The survival of patients with smoldering chronic lymphocytic leukemia is similar to an age and sex-matched normal population. There is significant heterogeneity in the clinical course of chronic lymphocytic leukemia that is in part attributable to the biologic differences between tumors. Scientific advances have led to the discovery of chromosomal abnormalities, deletions 11q or 17p, gene mutations, unmutated immunoglobulin variable region and p53, and serum or cell surface markers, increased beta-2 microglobulin, zeta-associated protein 70, and CD38 expression, that may confer poor prognosis. The deletion 13q is the most common cytogenetic abnormality, occurring in 55% of patients, and it has a favorable prognosis, survival for longer than 10 years. The deletion 11q and deletion 17p occur in 18% and 7%, respectively, with shorter survival times of approximately 7 and 3 years, respectively. Current national guidelines take into account some of these factors in their treatment recommendations. Despite his early stage by the modified Rye classification, GOR had an 11q deletion, conferring a worse prognosis. He would be encouraged to start treatment. However, as a result of having minimal symptoms, GOR chooses to delay treatment until he becomes symptomatic. GOR returns to the hematologist every 3 months and has no new symptoms or infectious complications for about 2 years. At that time, physical examination reveals enlargement of cervical, inguinal, and axillary lymph nodes, hepatomegaly, and splenomegaly. His WBC has increased from 34,000 cells per microliter 6 months ago to 68,000 cells per microliter today, 85% lymphocytes. His HGB is 11.7 grams per deciliter, and his platelet count is 140,000 cells per microliter. So my next question to you reads: what treatment is now indicated? Indications for treatment initiation in chronic lymphocytic leukemia include significant anemia or thrombocytopenia, progressive disease demonstrated by lymphadenopathy, hepatomegaly, splenomegaly, a lymphocyte doubling time of less than 6 months, persistent B symptoms, fever, night sweats, and weight loss, threatened end organ function, and recurrent infection. Patient performance status, comorbid conditions, pharmacoeconomic variables, and social support should all be taken into consideration when selecting treatment. Cytogenetic results will also be considered. Because GOR has experienced significant lymphadenopathy and hepatosplenomegaly, he should initiate treatment at this time to prevent further deterioration of his hematologic and immune function. We will now briefly look at the initial therapy. Chlorambucil therapy for chronic lymphocytic leukemia has historically included use of an alkylating agent, most often oral chlorambucil or cyclophosphamide, with or without prednisone. A variety of daily and intermittent dosing schedules have been reported. The overall response, abbreviated as OR, rate to chlorambucil was approximately 40% to 60%, but only 3% to 5% achieved ACR. Chlorambucil use has diminished, and the use of purine analogues, such as fludarabine, is more common in clinical practice. However, chlorambucil is recommended for patients older than or equal to 70 years, or in younger patients if they have significant comorbidities. Chlorambucil is often used in combination with monoclonal antibodies. Next we will look at fludarabine. Fludarabine is an active agent in the treatment of chronic lymphocytic leukemia. Fludarabine monotherapy at a dose range of 25 to 30 mg per meter squared per dose IV for 5 days has shown a 70% to 80% overall response rate, and CR rates of 20% to 30% with increased progression-free survival, abbreviated as PFS. Fludarabine may have improved overall survival compared with chlorambucil, but results are inconsistent across studies. Toxicities associated with fludarabine are typically mild and include fever and immunosuppression. Increased incidence of infection and autoimmune hemolytic anemia are also associated with fludarabine therapy. Infection prophylaxis should be considered in elderly patients and patients with advanced disease or renal dysfunction. Fludarabine has been combined with other chemotherapy and monoclonal antibodies, including cyclophosphamide and rituximab, in an effort to prevent multidrug resistance and increase response. Although combination regimens including fludarabine have demonstrated higher response rates and progression-free survival, no difference in overall survival has been consistently demonstrated. Additional toxicities of the combination regimens include higher rates of leukopenia, thrombocytopenia, nausea, vomiting, and alopecia. Next we will look at bendamustine. Bendamustine, a nitrogen mustard, alkylating agent, was approved in 2008 for the treatment of chronic lymphocytic leukemia. In clinical studies, it has been shown to be superior to chlorambucil with overall response and CR rates of 68% and 31%, respectively. A typical dose and schedule is 100 mg per meter squared IV on days 1 and 2. Toxicities include infusion reactions and myelosuppression. It is often used in combination with rituximab and primarily in patients older than or equal to 70 years or those with comorbidities. And now we will consider rituximab. Rituximab is a chimeric human murine anti-CD20 monoclonal antibody. The CD20 surface antigen is expressed on a high percentage of chronic lymphocytic leukemia cells. Rituximab monotherapy as initial therapy for untreated patients at a dose of 375 mg per meter squared weekly for 4 doses yielded overall response rates of 58% and CR rates of 9%. These are lower than those seen with cytotoxic therapy, with a disappointing duration of response. Therefore, rituximab monotherapy is reserved for patients with significant comorbidity. Generally, It is used in combination therapy with cytotoxic agents. We will now look at combination regimens. A regimen for initial treatment is the combination of fludarabine, cyclophosphamide and rituximab, abbreviated as FCR. In a study of first-line treatment of chronic lymphocytic leukemia, patients were treated with fludarabine 25 mg per meter squared IV on days 1 to 3, cyclophosphamide 250 mg per meter squared IV on days 1 to 3, and rituximab 375 mg per meter squared IV on day 1 of cycle 1, escalated to 500 mg per meter squared in subsequent cycles. Overall response rate was 96%. Toxicity of this regimen included infusion-related reactions, nausea, vomiting, and myelosuppression. Grade 3 or 4 neutropenia was frequently noted with an infection rate of 20%. The fludarabine, cyclophosphamide and rituximab regimen is recommended in patients younger than 70 years without significant comorbidities or older patients without comorbidities, and in any patient with the unfavorable DEL 17p cytogenetic abnormality. Results for a bendamustine plus rituximab, abbreviated as BR, combination regimen have recently been reported. In a study of 117 patients with previously untreated chronic lymphocytic leukemia, patients were given bendamustine 90 mg per meter squared IV on days 1 and 2, and rituximab 375 mg per meter squared IV on day 1 of cycle 1, escalated to 500 mg per meter squared in subsequent cycles for up to 6 cycles. Overall response was 90% and CR 33%. Trials are ongoing to compare this combination with fludarabine, cyclophosphamide and rituximab as first-line therapy for chronic lymphocytic leukemia patients who are able to tolerate combination chemotherapy. A published interim analysis showed an objective response rate that was identical in both groups at 98%. However, the adverse effect profile favored bendamustine plus rituximab with a higher rate of toxicity in the fludarabine, cyclophosphamide and rituximab group, 91% for FCR versus 79% for BR. The bendamustine plus rituximab regimen, like chlorambucil with or without prednisone, is commonly used in patients older than or equal to 70 years or in younger patients with comorbidities. In summary, first-line therapy for patients older than or equal to 70 years old or with significant comorbidities generally includes bendamustine plus rituximab or chlorambucil. For younger patients without comorbidities, 3 drug combinations such as fludarabine, cyclophosphamide and rituximab may be offered. GOR is now 68 years old with no significant comorbidities and is likely to tolerate treatment with fludarabine, cyclophosphamide and rituximab. GOR receives fludarabine, cyclophosphamide and rituximab as initial chronic lymphocytic leukemia therapy. After the 3rd cycle, he has complete regression of his lymphadenopathy and hepatosplenomegaly, and his WBC count decreases to 9,000 cells per microliter. He finishes 6 cycles in total. GOR comes to clinic 1.5 years after completion of therapy. A CBC is obtained that reveals a WBC count of 55,000 cells per microliter, 70% lymphocytes, hemoglobin of 10 grams per deciliter, and platelet count of 90,000 cells per microliter. On physical examination, GOR is found to have cervical, inguinal, and axillary lymphadenopathy with no palpable splenomegaly. He complains of excessive fatigue and fever. Therefore, GOR has recurrent disease. What therapies may be helpful to him at this point? Second-line therapy should be selected based on criteria similar to those used for initial management. Relapsed patients are classified as treatment-sensitive if the disease relapses more than 3 years after fludarabine cyclophosphamide and rituximab treatment. GOR's relapse occurred less than 2 years from completion of fludarabine cyclophosphamide and rituximab therapy. He is classified as refractory to his first-line regimen. He is still younger than 70 years old with minimal comorbidities and is a candidate for aggressive second-line treatment. We will now consider treatment-sensitive cases. Treatment-sensitive patients are retreated with the same regimen given for first-line therapy as long as they are expected to tolerate treatment. For patients who are older than 70 years or those who have comorbidities, the regimen may be changed to one with less toxicity. These less toxic regimens include dose-reduced fludarabine cyclophosphamide and rituximab, obinutuzumab, chlorambucil, ibrutinib, bendamustine plus rituximab, single-agent rituximab, or cyclophosphamide prednisone rituximab. Next we will consider treatment-refractory cases. Treatment-refractory patients will be offered a regimen containing at least one anti-cancer agent not previously given. For patients older than 70 years with comorbidities, options include chemo-immunotherapy combinations, dose-reduced fludarabine cyclophosphamide and rituximab, dose-reduced pentostatin cyclophosphamide rituximab, rituximab chlorambucil, bendamustine plus rituximab, and high-dose methylprednisolone rituximab. Other options are ofatumumab, obinutuzumab, and ibrutinib. Patients younger than 70 years old without significant comorbidities have several options, including combination chemotherapy, chemoimmunotherapy, ibrutinib, and monoclonal antibodies and consideration of allogeneic hematopoietic cell transplantation. In conclusion, GOR's disease relapsed within 18 months of completing initial therapy and is treatment refractory. Therefore, he should receive a second-line regimen, which includes an agent to which he has not been previously exposed. GOR received fludarabine cyclophosphamide and rituximab as his initial treatment. Therefore, the bendamustine plus rituximab regimen is a good choice for him now. In addition, he is younger than 70, in relatively good health, and should tolerate combination therapy. 6 weeks after the initiation of bendamustine plus rituximab, GOR complains of progressive shortness of breath and fever. On questioning, he reveals that he quit taking his trimethoprim sulfamethoxazole and valacyclovir because, "I felt fine." Radiography of the chest reveals bilateral infiltrates. GOR is admitted to the hospital for further evaluation and treatment. A CBC reveals a WBC count of 22,000 cells per microliter, 80% lymphocytes, and an absolute neutrophil count of 800 cells per microliter, hemoglobin of 11 grams per deciliter, and platelet count of 70,000 cells per microliter. Quantification of serum immunoglobulins reveals profound hypogammaglobulinemia. So my next question to you reads: what are the possible causes of GOR's pneumonia, and what treatment is indicated? Infections contribute significantly to morbidity and mortality in patients with chronic lymphocytic leukemia. The immune compromise of chronic lymphocytic leukemia is attributable to immunoglobulin deficiency, abnormal T-cell function, neutropenia, and chemotherapy, which contribute to the increased rate of both common and opportunistic infections. Up to 80% of patients will develop an infectious complication. Therefore, the use of IV immune globulin, antibacterials, trimethoprim sulfamethoxazole, and antivirals, acyclovir for herpes simplex virus, and vaccinations, influenza, and pneumococcal, are common. Opportunistic infections are particularly common in patients receiving a purine analog. The use of supplemental IV immune globulin for prophylaxis of future infection is often used in patients with low immunoglobulin levels, IgG less than 500 mg per deciliter, and recurrent infections requiring hospitalization. Hospitalization is warranted for GOR so he can receive broad-spectrum antimicrobials for neutropenic fever and a thorough workup for opportunistic etiologies. Because GOR has a significant pulmonary infection requiring hospitalization with a documented hypogammaglobulinemia, prophylactic IV immune globulin therapy should be considered to prevent future infections. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 467.